Our next speaker is Wendy Kipling, who will talk about psychosocial disability, the NDIS, clinical mainstream services, business as usual, or case for change. So, Wendy doesn't say in the bio, but Wendy's very passionate. She's been employed with the ACT government as mental health officer on NDIS Taskforce, and she's been in the role for about 18 months and was appointed to bring the experience of the mental health sector into the planning and implementation of NDIS in the ACT. Wendy's got a background as a registered nurse with extensive experience in mental health both in Australia and the UK. And Wendy certainly has a lot of passion about recovery-orientated services, so I'd like to introduce Wendy. Thank you.
Oh God, I'm so nervous. Just a little bit about myself, I guess. Obviously my name's Wendy. My background is mental health nursing. I've been a mental health nurse for over 20 years. A lot of my experience has been in acute psychiatry, but I have a real passion really for my profession, but also for people with a lived experience of mental illness. Just want to start really just by talking a little bit about the ACT, and just to give people a bit of a picture of our trial. So we started our trial of the NDIS in July of this year, and we are going to be the first jurisdiction that will accept all eligible residents into the scheme by July 2016. And the ACT NDIS Taskforce is a group of people working in the Community Services Directorate, and obviously myself is included in that. We've got people from a disability background, we've got people from a housing background, and people from a health background on that task force, or people that are used to working with HAC services, for example. And we've tried to take a whole of government and a whole of sector approach in the work that we do. And our role has changed and is changing as the trial progresses in the ACT. And initially, before trial, we were looking at strategic policy and planning for the design of the NDIS and the input into the legislation. And now we're actually more focused on the implementation of the NDIS in the ACT. So as I said, we began our trial in July. It's really, really early days into the trial. We have to date, that came out in the quarterly report, one person who has identified a psychosocial disability with a Tier 3 package, but I'm aware that there are numerous people working in the pre-planning stages of the NDIS, and people that are actually engaged with the agency now in terms of their planning, assessments and interviews. We will phase into the scheme over 2 years, and the gradual intake will make sure that people are properly supported, hopefully, and receive the right services for their individual needs. We are taking an ages and stages approach in the ACT, which is obviously a different approach to the other jurisdictions. We're hoping, in terms for people with lived experience in mental illness, that this means that and providers means that we have more time. But one of the things I've noticed is that for some organisations, they prefer to have their band-aid ripped off rather than slowly taken off. So it's got two sides to that, and I can certainly answer questions on that. So the ACT mental health picture. Just to clarify, I guess, as well, my substantive position in the ACT government is the nurse manager of the adult mental health unit. So I'm still very much strongly situated in the health directorate, and I work across all areas of of ACT government, in clinical services as well as in the mental health sector, and that, which has been really interesting work. So we think the Productivity Commission think there's probably around 900 to 1,200 people in the ACT who are going to be eligible for the NDIS. We actually think on the ground that's probably nearer the 900. There are around about 350 people involved currently in ACT and Commonwealth funded programmes. So that includes FAMS programs, day-to-day living programs. That doesn't include the people that we are in Partners in Recovery at the moment, and that program has actually managed to work with people that have not had service before. So we may see a few more people in that program. And this compares to the roundabout. Public mental health services see about 8,000 people a year in the ACT. So, it's quite clear there that it's, 1 in 8, in effect. It's quite hard to get a real analysis of that, but that's what, when we're looking at the picture, that's where we think we're heading. Right, this thing. When we were looking at it from how we thought we were going to phase, what our phasing methodology would be in the ACT, and and therefore what the financial phasing and transition of funds to the Commonwealth would look like, we did a bit of mapping, and again this was hard in mental health services. We don't have a national minimum data set. The issues around what psychosocial disability were less clear then. But we asked our mental health providers to tell us who they thought that they had in their current services that would be eligible for the NDIS, who were in the 65 and over age bracket, and who we thought might be that, the famous Tier 2. We know more about Tier 2 now than we did then, but these are the questions that we asked. And our providers came back with some data for us, and that helped us look at how much money we were going to give into the NDIS, but later on in implementation, how we would actually start working with people. So this is how people will phase in the first year. The red line here is people that we've identified that are currently in the programs that will be transitioned into the NDIS, and this is the line of people that are not currently for the main, sorry, that's not the right way to say it, people that are receiving clinical services that we think will be eligible for the NDIS, because we've taken the approach, there's probably about 900, only 300 receiving supports now, and we really want, and it's our obligation really, to make sure that those people that aren't currently receiving service get benefits from the NDIS. So that's our first year, and as you can see, that's about 80 in the middle of that quarter, and then it goes down a bit. In the second year, the denominator changes a bit, and this is where we will see the peak in terms of people transitioning into the NDIS. So it's in the second year and late into the second year. This is what we found to be an interesting anomaly, and we're watching this. So these are people sorry, I should really go back. We're ages and stages, and that means we're going from oldest to youngest, so 64 down. That explains that a bit better. So this is the younger age group of people that are receiving clinical services but aren't in community managed services. And that's a bit of an anomaly for us, so we're trying to work that one through. So my role, it's like I say, it's been an interesting journey coming from a health background to now be working with people that are very much rooted in a community human services background and learning a lot about disability. My role was to, and the work that I've done is been evolving, you know, in terms of, well, what does that look like? You know, what is that role? So it's been ensuring that the mental health voice is being heard in our ACT implementation, supporting the sector, supporting consumers and carers, supporting clinicians, and from a jurisdictional perspective, ensuring that the mental health voice is heard in any national policy work. We've had a bit longer to prepare for our trial launch, and some of the work that we have done, the major piece of work that we did last year to prepare people for the NDIS was the enhanced service offer. So the enhanced service offer was a series of grants that people could apply for that were aimed at people, and it was an individual, so that, you know, to try and get those learnings around how you manage an individual budget. So learnings for people with disability and people with psychosocial disability, but also for providers. So providers could start getting used to people knocking on their door saying, I want this, how much does it cost, and what, you know, and in those discussing those support arrangements one-on-one. Obviously we ensured that people with psychosocial disability were included in this. In the ACT, our experience of individualised funding is not strong, and that's true of the disability sector, and we have no experience of individualised funding for mental health consumers. So this was a real test for us, and it was a real test of the role of the mental health officer as well. My colleague sat over there, Claire. In my workplace, people, I'm known as the person that says, oh, what about mental health? What about people with psychosocial disability? You know, so to do this was been absolutely fantastic. So 593 people identified with a primary psychosocial disability applied for a grant under the enhanced service offer, and there were a range of grants that people could apply for: aids and equipment, quality of life, and things like flexible supports, and there was a range of different amounts that people could apply for. 245 people were successful, which actually for me was we were just so pleased with that. When we started this work, we didn't really think that we would get, I said, if I get 20 people with the grant, then I'll be really happy. So to get 245 and the 593 applying was just phenomenal. And one of the ways that we did that, and I think, to be quite honest, yesterday I heard a lot about impairment, and I heard a lot about deficit, and I heard a lot about how organisations were working with consumers around that so they would be able to get into the NDIS. We didn't do that. We worked with people and we asked them to think about their goals and aspirations. We asked them to think about their dreams and their hopes and what a ordinary life could look like, what a contributing life could look like. And that was important. Even if people weren't going to be eligible for an ESO, we had a limited amount of money, so not everybody was going to get an ESO. So if they didn't get one or they weren't eligible, how could that translate in the rest of their life? So they didn't have a life that was necessarily dependent on service or designed by service. We've also done some other work. We did a small supported decision-making project, and the providers and the organisations that helped us with this work are in the room. So, if you want to speak to them about their projects, I think that would be a really good idea. We did some work around connecting communities, and that was working with a local provider to try and make some links and bridges between what would be the disability world and what was the mental health world. And actually, that organisation played a central part in that many people applying for a grant, to try and build some of those bridges. And we're hoping that will also work with the local NDIA, so they actually can be rooted and go to the people. So you're not sat in an ivory tower in an office, you're actually where people are, and that's why we got so many. You really need to go to people. We did some work around peer workforce, and again, I know that the Mental Health Consumer Network are talking about that this afternoon, so I won't go into that. We did community conversations, and again, it's going back to the idea that people can have a good life and should have a good life, regardless of whether they're eligible for the NDIS or not. And again, going out to where people are to do that. And we established a peer-led working group, and that was people, a mix of people with disability, with intellectual disability, with general disability, families of people with disability, and people with psychosocial disability and or a lived experience of mental illness. And we're hoping that group will continue to work over the next 2 years when we get our further funding. Everybody's talked about recovery, so I'm not going to go into it, massively. There's some eminent people in the room that could probably talk about it a lot better than I could. And we know that these are issues, so I'm not going to, dwell on those. But I do want to ask the question, I want other people to think about these questions. I hear a lot that we do recovery. I heard a lot yesterday about what a wonderful service system we have, and for the main, we do have a wonderful service system, and there are some really good programs out there, and there's some really committed people that I've had the pleasure to work with. But I still say, and this is as true of clinical services as it is of community managed services, do we really do recovery? What does that mean, and who does recovery belong to? Lots of times I'm hearing providers saying that we're doing that, but actually to get them to say what that means is quite hard. Are consumers given choice and able to co-design their supports, or do we fit them into programs? And that's not, that's a way that government has funded our services, that people have to fit into those silos. But, again, it's a question. Are supports self-directed, really self-directed? And are supports outcome-focused? And I mean really outcome-focused when I say that. So I'll leave that, because I'm not going to, huge argument or discussion, but those are questions that I've got. So into clinical services, a lot of my work has been working with clinicians in our clinical services, because we know that the majority of people that are going to access the NDIS for psychosocial disability will have clinicians in their life, or have had clinicians in their life, or may have clinicians in their life again. And when we look at clinical services, although I think in the ACT we have come a long way in terms of recovery and person-centred practice, I also think we've got a long way to go. And the work that I've looked at and research that I've done is that clinicians can be barriers to people accessing individualised support, or they can be enablers. So what we've tried to do in our work is actually make them enablers in this process. And these are some of the questions that we are asking ourselves around the centrality of human relationship, about hope, and the fact that you need people around you who believe in your possibilities. I'll whisk through some of this stuff then. And so that's some of the work that we've started. We've got an implementation steering group, we've got a clinical leaders network, and some of the work that we've been doing. People will, particularly people in the trial sites, will know about the evidence of disability form, which has scared the bejesus out of some of our clinicians. So we have produced a tip sheet, which has been a really useful exercise in terms of clarifying for clinicians what they actually do. I know that sounds bizarre, but sometimes, you know, they haven't that clarity. So we use clinical language, and you know, that's one of the work we're doing. This is the work that we're really excited about at the moment. We are working with our sector and consumers and carers, and with partnerships with the NDIA to do a digital storyboard that is a training tool for workers, but actually centres the NDIS in recovery, and just takes that strengths-based approach in terms of how you can engage with people. So we're really excited about that. Partnerships and collaboration have been something that we've really focused on. Our implementation group is co-chaired by our sector peak. We're currently working with the Medicare Local, who are here as well today. We are working with consumers and carers in partnership with the NDIA, and I really can see that work progressing as more consumers come into the NDIA. So we had our local agency out at our clinical services the other day in one of our community mental health teams, and we really want to embed them in there, and working jointly with our peak. Our key achievements have been around building and strengthening some of building new relationships and strengthening other relationships in our sector, the enhanced service offer, communicating with our community partners, and the major achievement for me has been around the community conversations, and really about working with people with lived experience. Our key challenges is that ongoing changing culture that we really need to crack in terms of maximising people's opportunities for the NDIS. We've still got work to do around the capacity building and support for consumers. You know, so we've got some further funding with the thanks from the Commonwealth Government to do more of that work over the next couple of years, looking at supported decision making, looking at peer-led activities, you know, looking at co-design as well. And to me, the co-design element has been really, really valuable. The other area for us, I guess if we, and I think Nick Hartland touched on this yesterday, if we looked now at what services and programmes we thought would be in the NDIS, we might do it differently. And I think that we need to keep an open mind on that. We need to look at that and make sure that we have got that right through our trial. And how do we support people that are not going to be eligible that are in those programmes, or new people coming through the system that are not going to be eligible. So we really would need to make sure that we step up in terms of the ACT government's responsibility for providing supports for people with mental illness, and ensuring good national policy. And I'll end on that, and I think the key areas for me, you know, I've been doing this for coming up for 2 years now, and it's great to see Eddie on board doing this work, but, you know, we need to do it. We really need to get this right. Local area coordination is a particular area I think we need to, you know, really embrace and see how the NDIS can support our system. Thank you.
Okay, so questions? Have 5 minutes. David? People could just introduce themselves as well.
David Meldrum from the Mental Illness Fellowship of Australia. You weren't surprised to see me stand up, Wendy, were you? There's something bizarre about your figures. How can there be 8,000 clients of the mental health services and only 350 of them are in some form of funded community support? That's just not right. That's bizarrely at odds with the way it is in the rest of Australia. You know, you're saying that only 1 out of 23 clients of the mental health services get some form of funded community support outside clinical services. You know, in the rest of Australia, it would be a half. So your conclusion that there are only 350 people, in a sense, at risk here, and that you've got places for 1,000 must be very comfortable. I just don't accept it.
I don't think that there are 350 people at risk. I think there are 350 people that are going to have opportunities to transition into the NDIS. Those are our figures. Our work, the community sector there in the ACT is not a mental health sector, is not a big sector. And part of the issue why those people, there isn't more people in those services, there isn't enough community managed services in the ACT to accept referrals. Those are the figures that we have. We've done some analysis around that. Granted, it's not been, what's the word I'm looking for? The data and is not perfect, I guess, is what I'm saying, but those are the figures that we've got. I'm thinking that there's probably around another 200 or so more that are currently in our Partners in Recovery programme in the ACT, which is great because they've managed then to begin to work with people that have not had any access previously with services. But those are our figures.
Hello, Sally Regan from Hunter Partners in Recovery. Sorry, my question's about figures as well. I just wondered if you could explain a little bit further how you came at the 1:8 ratio, which I think you said was 1:8 would be eligible for the NDIS, if I got that right, and if you could explain how you arrived at that.
When we looked at our people that receive service from our clinical service system, again, because we don't have in mental health, which everybody knows, we don't currently have a national minimum data set. So the estimates that we were looking at was the people that had contact with our clinical services and people that had high frequent contacts with our service. We in the ACT, Public Mental Health Service System, saw around about 8,000 people in 1 year. The year that we looked at that. So 8,000 people that may have seen our service in the emergency department, that may have had access to our child and adolescent services, that may have only had one service episode with us, or people that may have ongoing, case management, if you like, from our clinical services. And that's where we look to get that, that's where that 8,000 figure is. From the Productivity Commission figures and the stuff that we know instinctively, I guess, that is that 1,000 or so. We think it's more than likely, and it's changing as we get more data and as we start learning from other trial sites. We are thinking there'll be around about 900 people. And the point I was trying to get across is that the NDIS is only going to provide support and services to a small minority of people in the ACT. And the role of our mental health system, both a public and non-public, is still vital in supporting those other 7,000 people.
Okay, one last question.
Tanita Taylor from Medicare Local in Brisbane. I'm just had a question about your ESO.
Yeah.
I'm just checking I understand. So it was like a readiness for consumers. So what workforce was used to do the work in supporting consumers and agencies?
Yep, so we, as part of the enhanced service offer, there is $7.7 million that we got to run that. We had employed individual planners and we tried our best to model the enhanced service offer of what was the eligibility around the NDIS. There was about 7 planners and those people, there were a couple of planners that had experience in the community sector of working with people with lived experience of mental illness. So there was those people. We then also worked a lot with our providers. So providers were supporting people, and we did get feedback on that in terms of the workload that and the impact on their services, which was taken on board. We also clinicians. We really tried to get into clinical services to make sure that they were supporting the consumers that they were working with to access the NDIS as well. Did we get it 100% right? No. And we still got people that think the ESO is the NDIS. We've still got concerns around people. We didn't have there was a huge team of assessors that did this, but we didn't have, and we didn't ask for massive amounts of forms in terms of evidence for disability. We didn't have that machinery that the NDIA has and will have, as numbers go through more. But I still think it was, and I'm really pleased, and it was a really good experience for people.